Alright guys, welcome to week 9. So this week we're going to give you a really awesome opportunity to watch our last quarter's video from Dr. Lubbe, who's going to teach you how to do the 3-minute neuro exam. So you're going to learn how to do some of the most important tests that you already learned this quarter and make them really efficient and do your exam in 3 minutes. So it's going to be really valuable for you, and I hope you guys enjoy this, and it's been a great journey for us, and I hope you learned a lot this quarter.
Cool. Let's go over some announcements. So, if you're not already subscribing and following us, if you're not already subscribing to our YouTube channel, click below and subscribe so that if you missed any stuff this quarter, you can go back and watch it at any time. This is our last week with you guys. We are working on coming up with new content for next quarter and kind of figuring out if we would like to do maybe some live sessions with you guys or come up with some new content for YouTube. So if you guys have any suggestions, or if there's anything that you guys really want to see next quarter, if it's you want to hear interviews from docs, if you want to hear more content from us, maybe going a little bit more in depth than we already did this quarter, or you just want stuff completely new, research, whatever it is, definitely give us your feedback so we can give you guys the best club experience and help teach what you guys want to learn. And lastly, I really just want to say thank you to you guys. I know we tried to challenge you a little bit more this quarter, not only being online and having to watch our videos without having that ability to have that face-to-face interaction. It might have made learning a little bit harder or easier. Hopefully, the ability to pause the videos and go back made this a great learning experience for you guys. Thanks for bearing with us through all of the technology things and trying to figure it all out. But I'm really grateful that you guys have watched all of our videos so far and that you're interested in learning neurology and really becoming that doctor of the nervous system. I know that's what Ropa and I that's all we want for you guys, is to really be able to know how to fix your patients and give them the best life possible. So thank you for that.
Absolutely.
And so now we're going to hand it off to Dr. Lubbe. Go ahead.
Thank you.
So, the goal for the conversation today with you guys is, I know that you cover a lot of different topics, and for those of you who don't know about any of kind of my history in neuro, I started on campus in October of 2009. I did 55 credits of prereqs to get into the DC program. Started taking my first Carrick module pre-DC. It was movement disorders taught by Dr. Carrick. By the time I graduated, I'd done a little over 1,200 hours. Ended up taking over the Neuro Club against my better judgment and pretty much my will in third quarter, the start of my third quarter. And by the end of the third quarter, I was the first student observing with Dr. Carrick when he was working on Sidney Crosby. Actually created all of the programs for bringing students in as observers, and within 6 months we had, I think it was 215 students that were trained to observe at the clinic. Ended up facilitating the scheduling, the training, the diagnostic training, and all the on-site therapies for 27 different grand rounds with Professor Carrick, one-on-one, which was kind of nuts. Good timing, right? Because a lot of things have come and gone since then, but I was just happened to be here in the same space, which was really cool. Ended up working with Carrick Brain Centers and also Cerebellum and all of those different spaces. So the reason I mention that is I wanted to go over a couple of basic neuro exam things to make it practical and to make it quick, especially as you're working into getting into student clinic. But also the benefit of having a more intimate group like this is you can pretty much ask me any question that you want. There's nothing that's off limits, especially if you got to leave before 6 and you want to ask a question, feel free. But we can go anywhere from what it looks like to be a student, what it looks like to be an associate, what it looks like to run your own practice. I've had my own practice for 3 years. January was 3 years. And I have a very different style of practice. I have no CAs, no MAs, no front desk person. I'm the only person in the building. It's 100% referral-based practice. My office manager is actually remote. She's a concierge. And within the first 3 years, as of the beginning of February this year, we crossed $1 million in the first 3 years of practice. And I'm the only person in the practice with 100% referral-based practice, which I will tell you is freaking weird. And it's not something that I would tell you to shoot for, because it's not what I was shooting for. It's just what ended up happening. So we can go to any of those places. I have an identical twin brother, so my ability to be embarrassed or offended is very, very hard. So there's nothing that's off limits. You guys can ask anything. But one of the things that I've found really fascinating when talking to people about neuro is there tends to be a lot of really, really highbrow academia, but not a lot of practical application. Like people can go to a lot of courses, and they can do a lot of modules, and they can read a lot of books, and they can say a lot of big words like pontomedullary reticular formation, which sounds like a tongue twister. But how do you make it practical when somebody comes in? Like the bio said, I've experienced a little over 100 full-blown migraines per calendar year for 20 years. Unfortunately, today is another one of those days. So chances are good I'll probably get a little emotional because when I'm fatigued, my emotions get a little bit more closer to the brim. But today makes 21 this year already because I have actually a complex Chiari malformation. Not only do I have the Chiari where the cerebellum herniated, but it actually herniated enough that it mushroom capped and wrapped laterally around the brainstem. And then I have about a 60% tear of my atlantoaxial ligament. So when I flex, my dens actually retroflexes into my brainstem. So I have compression on all 4 sides because I got run over by a car when I was 8. Failure of a spot by my twin brother. Really, really missed the boat on that one. Also, I'm the only person that I know that was run over by a car and then subsequently spanked by my dad for being run over by that car. So if anybody wonders how your 8th year on the planet was, I can promise mine was probably interesting compared. But also had 2 concussions in high school and was hit by 2 drunk drivers by the time I was 21. So unfortunately, my head and neck didn't have the greatest experience getting to 22. But I went to 21 specialists over 9 years to get a diagnosis, had never even been to a chiropractor, and actually ended up getting put in the hospital 3 times by different chiropractors because it was contraindicated to adjust somebody like me. So I'm actually a chiropractor who can't get adjusted through normal osseous adjustments. I can through AO and a couple of other techniques, but even then it can be provocative. So I can literally go anywhere that you guys want, from a patient to a doctor to somebody who can't even be freaking adjusted, which is kind of ironic as somebody who loves chiropractic. What's up, brother? So yeah, lots of different spaces. But one of the things that I've found really fun with learning some of the acronyms of doing a quick little exam is just making it fun, making it funny, whatever the case may be. So this one is one that I've used for a long time. You guys know 7 longitudinal levels of lesion? Okay. So every peripheral nerve survives by contacting the cortex. That's my one. Does everybody know what these are? Can you shout them out? What's the E? Cool. Okay, if you answer, you can't answer twice. It's a crowd participation here. What's the P? I'm going to give you a guess. It's actually what it says. There you go. Somebody got it. The S? Spinal cord. B? Thank you. All the way in the back. C? Somebody said it. It was great. A little mumbled, which is interesting because this organ helps with fine motor coordination and speech. Cerebellum. Cool. The? Thalamus. And then the last one I'm going to throw out there is also pretty obvious. Okay. So what I wanted to show everybody, I heard that you guys did some of the 3-minute exam last week. Also, for what it's worth, I sent Rope the document that's written up. Do you guys still use the Intro to Funk Neuro Manual? Yes. Okay, cool. So that was actually something that I wrote for the club like, I think 7 or 8 years ago. So it's cool that you guys are still using it. Because I was like, this is complicated and I just need everything in one place. So that's, I'm all about, if anything that you guys hear that you're like, do you have a resource or a document that's already written up? Yeah, probably. And if you want it, happy to give it to you. So I gave Rope the type up of it and then also the link for a video that we did at Brainstorm in Parker a couple years ago where there's actually 38 videos. It's kind of like a weekend seminar where they had everybody come out and speak on different topics. And that playlist is still up on YouTube. So the link is in the document that he can get to you guys and you can watch any of that. Because the 3-minute exam is actually unpacked in the course of an hour and you can go back and watch it. But the main thing that I wanted to do was just kind of, again, reorient you to this. Ask you a couple of questions about why you think it's relevant. And then also go over a specific case study that we had happen in the clinic earlier this year to try and dialogue with you what in the 3-minute exam would help me to understand what's happening with this person and then why the treatment worked or may not have worked based on what her diagnosis was. Does that sound cool? Okay. Everybody good with that? How's it going? What are you riding, man? Nice. I used to do a VFR 750. I did a VFR 750. Nice. So, sorry. Gotta ask. Gotta ask. No, it's a fun bike, man. It's not great to learn on. It's a little too powerful, but it was fun. Cool. So, the one that I wrote here quickly, just because sometimes you can be cheeky and it's funny, okay? All right, and Rope helped me out with it. We were trying to figure out what to put for the O, because I was trying to go with ostensibly, and I was like, I think it might be a little hard to say that. Okay, but it's just the acronym for the different tests. But regular drives for French fries put people seeking chocolate in objectively great danger. Okay, so it's just one of those things where you got to look at how can you try and remember some of these things. So I'm going to go through each of these quickly, and for the sake of how much time we have, and you guys are your ninth week of various quarters, you're absolutely drained, right? It's tiring. You're doing labs next week, so try and have it be a little bit more interactive. Okay, so when you're looking for Romberg's, what is the number one thing that they beat into you in school that's a positive for a Romberg's? Okay, I can tell you in 10 years, 10, of being around funk neuro cases, you know how many people I've seen fall doing a Romberg's? Big old donut, okay? There are 2 people that I've seen fall, and this is one of the most fascinating things that I saw when doing rounds with Carrick. So I'm going to try and tie in a couple of practical examples for you, because as of right now, I don't think any of you are in practice, right? What quarter are you in? Good? Awesome. I feel like I've seen you before. Might have. There you go. Got to trust a man with a beard. Okay. You too, brother. I see you. It's coming in. It's coming in. I've never seen anybody fall on a Romberg's ever. Not personally. Is it possible? For sure. Is that somebody that you're probably going to have in your practice when you first get out? Probably not. If you try to take on that kind of patient, you better have a lot of training, okay, because that is a severe issue. But also, when we learn most of these tests, they're expecting you to find the person who's so pathological that what are they normally going to end up having you do as soon as you find that patient anyways? Send them out, okay? I got referred back and forth between so many specialists by the time that I gave up and just decided to become a doctor, that for the love of God, if you don't need to refer somebody out, don't refer somebody out. But if you get somebody that drops as soon as they close their eyes, you probably don't need to have them in your office, okay? But in 10 years, it's never happened to me. But while I was doing rounds, there were 2 specific situations, and I'll never forget it, that there was a guy that kept having a positive Romberg's. And one of the clinicians brought him in for Dr. Carrick to look at him. And as soon as he stood him up and he closed his eyes, this guy hit the floor. And it was so interesting because this guy's standing up in front of the table right here. The table's behind him. And I'll be Dr. Carrick for a second, okay? This guy closes his eyes, drops to the floor, and Dr. Carrick does this. He steps out of the guy's way. What are you trying to do if somebody drops during a Romberg's? Yeah. If a patient falls, you need to catch them. And I'm sitting here with a video camera going, this is contrary to popular belief and what I've been trained in. And what ended up happening, Dr. Carrick goes through a couple more questions, says, okay, we're going to take you in for another V&G. I want to ask a couple of questions to your doctor. Takes the person around the corner to do another V&G and said that it's completely malingering. It's faking. And they're like, what do you mean he's faking? He's dropping. He's got the severe POTS. We've seen all this other stuff. He goes, I'm not denying that there may be a mental or an emotional health factor. I'm not denying that there may be symptomatology. But if somebody is spontaneously dropping like syncope, like true syncope and blackout from POTS, postural orthostatic, what are they going to have if they're falling regularly? Any guesses? Bruising. This guy didn't have a single bruise on him. What is the person doing on the way down, regardless of whether or not it looks like a presentation for a positive Romberg's? They have to be catching themselves. So if you work with people who are having some degree of vestibular complaint with spontaneous falls, and you don't see bruising, it doesn't mean that it is exaggerated, but that's high on the list, possibly. But if you don't see bruising, you need to very quickly ask, what is happening in the intervening space for them to drop before they hit the ground that's causing them to catch themselves? Because if there's no bruising, it's not a true drop, right? I've worked with patients that have come into the office that haven't had a drop attack in the office, but they have fallen down in bathrooms and hit in bathtubs and toilets and floors on the way down, broken jaws, severe head injuries. That's somebody who didn't realize that they were falling until they woke up in the hospital, right? So if somebody doesn't have a bruise, it's not a true Romberg's, okay? So DDK, everybody familiar with what a DDK is? What does it look like? Show it to me quick. This is a participation exercise as well, okay? Put it up, all right? How do you guys, is everybody okay if I just randomly ask for somebody to participate in this? Okay, all right, you can do it from the seat if you want, it's okay. What are your instructions for somebody during a DDK? Skylar, what do you tell somebody if you're going to give them a DDK? Okay. Okay, normally, how many of you guys have actually done a DDK on somebody who didn't know what you're asking them to do? Okay. What is generally the confusion with a DDK? What does somebody normally do when you ask them to do that process? Yeah, they'll go from the elbow, or what do they normally not do? They don't go all the way up, right? They'll normally just go like this, okay? So remember, when you're doing this, this is an agonist-antagonist relationship. And the fascinating thing, you guys, why the finger tap test is so helpful and other things are helpful, almost everything that you're looking at is a push-pull relationship. It's an antagonist-agonist relationship of how are you working with flexor and extensor compartments, right? Because flexor, extensor, internal, external rotation. Also, I'll show you guys some finger exercises that I do with patients that if you really cue up into how somebody relates to extension and flexion, really helpful to actually diagnose a bunch of other things. So remember, with the DDK, you're asking somebody to go into full external rotation as much as possible. A lot of people think it's a speed test. It's not as much a speed test as it is full external rotation to full internal rotation, okay? What are the two ways that you generally do a DDK? Does anybody know? Arms out and arms in. Why do you check arms out versus arms in? Different muscle groups for sure. Yeah, and say that last part again. Different innervation points for sure. If you thought about real estate in the brain from like a departmental systems standpoint, which one is doing the DDK? What primary systems are you looking at to check DDK? Cerebellum, frontal, prefrontal, for sure. Okay, you got a lot of things for muscle tone. I'm not going to go into a ton of basal ganglionic, all that. By the way, just so you guys know, okay, one of the things that every student that I've worked with, and I ran the Neuro Club for 2 years, did 1,200 hours before I even graduated school, met with a lot of clinicians in a lot of different spaces. Everybody gets really excited about knowing pathways and really excited about knowing all the systems. If you can't observe a patient and you don't have an idea as to what to do for an intervention, I'd probably maybe lower the bar on how much you need to know the language and the jargon. Because do you know how many patients I talk to using neurological language? This many, okay? Until they ask me to explain it to them technically, I don't explain it to them technically. Because the longest exam that I had when I was going in, I went to 21 specialists over 9 years before I got my Chiari diagnosis. And after that, they were like, well, we can offer you a decompression surgery, but that's about it. In the 21 specialists that I went to, do you know how long my longest exam was? And that's walking in, saying hi, explaining it, in exam, recommendation for next steps, and the doctor leaves the room. 11 was the longest, okay? Most of them were 3 to 6 month wait. If you get time to work with patients, my intake exam is 2 hours, okay? I do a 1 hour case history with somebody, and we always ask the same question to finish the exam, which is there anything that we haven't discussed or you haven't asked that would make this conversation feel incomplete? If they answer no, we start the exam. But if they don't answer yes, I tell them, look, I'm going to have to shorten the exam or we're going to have to do another exam. But you got to understand, patients are more inclined to pay for an additional session to make sure that you understand where they're at than for you to jump straight into an exam without knowing exactly where they're at. Fair enough? Okay? So I don't use technical language for what it's worth. But the reason I say this is, remember, when you're doing this one, which primary joint is being loaded for this exercise? Glenohumeral, right? Shoulder. And this one? Elbow. So if you know cerebellum, for what it's worth, and I know you guys are recording it, so if this is interesting to you, you'll go back and watch it again. So if I go too fast, I apologize. Just stop me, okay? But if it's important, you'll go back and do it again. Because I use a rule of 3 whenever I learn something. Once to be exposed to it, second time to digest it, third time to integrate it. And I can promise you most of this stuff takes more than 3 times to learn. It's just complicated. Cool? But which part of the cerebellum handles the glenohumeral joint? Anybody remember? Globus, right? Globus for glenohumeral, and then elbow? Emboliform, okay? So remember, when you're checking these things, as you start to learn more about the cerebellum, the long story short, to make it really practical, when you check it here, if it breaks down, you're dealing with newer parts of the cerebellum, so you probably want to look at more complicated issues with cerebellum, like fingers and tongue and coordination of cognition. Like there's more fancy parts of the cerebellum that are dealing with more complicated tasks. The elbow and the fingers, especially once you go from elbows to wrist and wrist to finger, the more distal you go, the more complicated and the newer and the fancier the cerebellum is. So if you're going with glenohumeral, you're probably not going to have somebody that's dealing specifically with, for instance, speech issues or swallowing issues. You could be dealing with swallowing from the midline, but you're probably going to be dealing with more gross motor versus fine motor as you move down the arm. Okay? Does that make sense? How's the speed? We doing okay? Right on. All right, so 4, finger to nose. Does anybody not understand the difference between finger to nose and finger to nose? Is that a new one? Cool. Can I borrow you for a second? Well, you're taking notes. Can I borrow you for a second? Okay, awesome. I want to make sure you get, I understand the note taking. I get it. Okay. All right, y'all, this is Ryan. Give it up for Ryan. There you go. Okay. U.S. Open, right? Never been myself, but I hear it's fine. It's an expensive sport, and I was an immigrant kid. I couldn't do it. Okay, so I want you to close your eyes. I'm going to touch a finger. I want you to touch your finger to your nose. What speed are you asking for in this? This is the interesting thing. Depends on what you're looking for. If you go for speed, you're looking for gross changes. But if you want to look at accuracy as well as parietal components, you want to slow it down, because the slower you go, you're actually going to change your map with relationship to who you are. For instance, okay? We'll do it the first time as fast as you can. I want you to go out and back in, and then we're going to do it slower, okay? Okay, so fairly accurate, right? But now we'll go as slow as we can, okay? So I want you to do it over a count of 5 at least, okay? Okay, cool, and drop your hands. So you guys might not see it from where you're sitting, but any difference between the faster and the slower? Anybody want to throw it out? Hi, good to see you. Anybody see anything? Subtle? Major? Nothing? Sure. Anybody else? Okay, it's all good. No stress. My favorite thing when Dr. Carrick would ask a question is everybody would go like this. Okay? And the fastest way to get kicked out of the room, and I'm going to use you because you're the president, was to answer a question. If I feel like you knew that. But if you don't know, just say, I don't know. That was the fastest way to be safe. But if somebody automatically, spontaneously came up with an answer, Dr. Carrick would actually have them leave the room. It's like, nope, somebody else. The reason I say that is there's actually nothing different between the two. One of the biggest things that happens, and I wanted to use Ryan as an example there, one of the biggest things that happens in the functional neurology world is we assume that somebody's going to have a pathology. Like, we assume that people are not healthy, okay? There are times that you're going to do something, you're like, yeah, there's nothing there. It's not significant. Or you need to look at the rest of the exams and go, is that worth spending my time trying to diagnose or intervene? Is it a big enough issue? For what it's worth, there was actually a slight hesitation on the second time his arm came in on the faster one versus the slower one, but not enough that I'd go, that's worth looking at. Cool? All right, thanks. Have a seat. Oh, wait, one more time. Arms back up. Okay. All right. So this time, one of the things you can also do, what's the biggest way to probably see the difference between 2 different types of systems whenever you're doing anything hand-eye coordination? Dual task, for sure. What else could you do if it's a hand-eye coordination that would make it a very different test? Close the eyes. Yeah, and pretty much anything that you do in a neuro exam, you can just close the eyes quickly. So first, I want you to just go through this hand from thumb to pinky as quick as you can with your eyes open. Okay? Okay? Now what I want you to do is switch between, I want you to do thumb, index, middle, ring, pinky. Okay? Nope, just go in that order. So thumb, index, middle, ring, pinky. As quick as you can.
Hands or one?
No, I just want you to, you're going to go through all of the fingers, but you're going to switch hands as you translate through a finger. So I want you to do it in this order. 1, 2, 3, 4, 5. Hang on just a second. Sorry, y'all. Okay. Does that make sense? Okay, cool. Give it a shot. See if you got it. Cool. Okay. Dual tasking, right? You guys ever seen that one? That's kind of different, right? So you can do dual tasking just by giving instructions. Also, it's one of those things of a front load. So finger to nose is where I'm actually doing this now. How many of you guys have been shown that you can do a visual exam at the same time as this particular test? Has anybody seen that? Okay, because here's the thing. When you do exams with patients, it's not out of the question that you get one shot at being able to see it. So one of the things you want to do is try and see a particular eye movement for the first time based on your exam. So if I'm doing a pursuit with somebody, I can actually use a change in location of my hands to check their saccades and their pursuits using a finger to nose. Okay? So for instance, if you just use and finger to nose, you're just going to use one hand at a time. Okay, so take this index finger, make a fist, open the finger. Okay, I want you to touch your nose. You're going to touch my finger, touch your nose, come back to my finger. Okay, I'm going to move my finger around so you just catch it. Okay, so go back and forth. And here's the thing, pause. Go back to your nose, pause. Okay, in this motion, you see how this is a uniplanar motion? This? What am I trying to also check when I'm checking agonist to antagonist, right? So what I want you to do is finger pad to finger pad, okay? So internal rotation to external rotation. If you do this, it's going to be a very different result than if you do that, okay? So finger pad to finger pad. Okay, so right now I'm looking at gaze fixation. You can see where his eyes are yoked, if they're conjugate, if they're different, if he's got a little exotropia on the left eye because it's out a little bit. I'm not going to tell him when I'm going to move it. I'm just going to move it. The first time I move it, I get a chance to see his saccades. Then, if I start to slowly move the finger, I get a chance to see pursuits. Make sense? Okay, so you can check up right saccades, down left, up left, right? And then you can also check pursuits while you're doing that. Okay, have a seat for me. Thank you, brother. Round of applause for Ryan, y'all. Round of applause. All right, I work with an organization that whenever they have somebody speak, the first thing that everybody does is they give a standing ovation before they start. I think that's kind of cool. It's like, we don't even know if it's going to be any good, but we're going to give you a standing ovation before you start. Pretty fascinating. By the way, as I think about that, I'm going to sprinkle in some other things as we're talking about. If you guys have not through your... Sorry, I'm having literally like 4 trains of thought happen right now, so I apologize. If you have not thought through your business plan, and I don't know about anybody else, but have you had a great experience and really learned a lot through the business plan classes? If you've taken them already? Some of the weekend ones for sure. Yeah, but the ones that are like the standard process and yeah, okay. If you want something that's actually going to be super helpful for fleshing out your idea of whatever it looks like you want to do when you graduate, I recommend looking up plywood people and doing a program that they call PATH. Okay? I can tell you, yeah, plywood people, and it's called PATH. I can tell you personally, I have spent $3,000 on a single day of business coaching, and it was very, very helpful and very, very effective because I was in a practice that was making $300,000 a year. So making $3,000 of investment for a business coach at that point, probably a good idea. But if you're coming out of school and you're trying to get an associate's job that will actually allow you to pay your rent, it might be a different space, right? PATH is only, I think, like $250 for a 6-week program, and they help you flesh out. It's basically getting a business coach with interaction, with a cohort, with a ton of resources for, less than 1 credit hour. It's pretty awesome. Okay, so what's that? Plywood people. Plywood people. It's a really great organization in Atlanta. That basically their tagline is they lead a community of startups doing good. And I think most people, if they're honest, when they get into chiropractic work, they're trying to do a lot of good work, trying to take care of people in a much more holistic, much more altruistic, idealistic way. So they're kind of cut from the same cloth of going, how do we effectively help people? And also, to be honest, man, most of the people that come to Neuro Club are not coming into it because they think they're going to have a high volume practice and make a crap ton of money doing a business. You guys are doing this because you're trying to effectively help people. Not that other clubs aren't. But we know when you start doing stuff where you're looking at neuro, it takes a little bit of time and a different approach. So if you're chasing high volume and revenue, it's probably not going to be the approach. I can tell you after having been in neuro for 11 years and knowing everybody who's come out and succeeded and not succeeded, Funk Neuro is not a high volume approach. Okay, so for what it's worth, if you want to connect with organizations in Atlanta that kind of have people working towards really doing a lot of good work, and you need resources for pretty much everything that's going to be a business side of things, like how do you connect with an accountant, how do you connect with a life coach, how do you connect with a business coach. Plywood's really, really, really helpful for that. Cool. Also, they're on site with the new Atlanta location at the East End, where there's like 7 breweries on site. So if you guys are also beer people, and there's like 7 breweries in their footprint, which is also great. Okay. So when we're looking at the DDK, the finger to finger to nose, for instance, one of the things that I also want you to look at, you can have both arms up and do another arm, so you can also see a parietal drift. But I'll be honest, guys, most of the people that I've seen do tests that involve a parietal drift, they don't see the parietal drift. They miss it a lot of times. Reason being, where are you, generally speaking, where are you looking when you're trying to see slight subtle movements on somebody? Does anybody know? So if I'm looking at a person who's in the middle of doing a DDK, where's my gaze? Generally in the middle. And is it a hard gaze or a soft gaze? Yeah. One of the other ways that's really helpful is I have a big mural on my wall at the clinic that says never give up, be resilient, and it's in big black block lettering, and I stand somebody in front of that. So if I look at one of the letters over their shoulder, my peripheral vision picks up everything. So if you actually have a contrast point past the person, you're going to actually see a lot more stuff than if you look directly at the person. So one thing is definitely look in the middle or look at the glabella if you're looking at eye movements. But if you're trying to do stuff where you're trying to track subtle movements and drifts, it's sometimes even better to look behind the person and let your peripheral vision pick it up. Cool? Okay. So, finger tap. Does everybody actually know what this is called? What the technical name of it is? Or how they found it? Okay, if you want to read a little bit more about it, it's called a UPDRS scale. Universal Parkinsonian Disability Rating Scale. That's actually where the finger tap comes from. All right? Does anybody know the things that you're looking at when you do a finger tap? Has anybody ever not seen this? Do you know what this is? Don't be embarrassed. If you have a little bit of a limbic experience because you're a little bit embarrassed, your brain actually remembers it a little bit better because it's like, that stung a little bit. I need to remember that that thing almost ate me. Don't go back to that place. So I answer questions all the time when I was in class and looked like an idiot because I answered them wrong all the time, but I remembered a lot more because I had a little bit of a limbic. It still looks stupid. What's up? That's why you like learning from Dr. Ellis. Yeah, that's my, yeah, y'all, I've known Dr. Ellis for 11 and a half years. We have a lot of history together. Yeah, for sure. And even harder. Yeah, for sure. Even harder. So I have a little bit of a leg up being naturally extroverted. But I went to 11 different schools before I graduated high school, so you got to figure it out. If you're an immigrant kid who's 80 pounds heavier than your identical twin brother, you got to figure out how to talk quick to stem the flow of the beatings, which is another story for another time. But the finger tap, everything that I say is true, I swear to God. You can fact check it, okay? If finger tap, what you're looking for is, and I was waiting for Dr. Ellis to walk in the room, just like we've summoned him. I feel his presence getting closer. We'll see if it happens. But if he does walk in the room, y'all got to do me a favor and just start cheering as soon as he shows up, and that'll be entertaining, okay? When you're doing a finger tap, the instructions for the finger tap are I want you to close your hand, open, and you guys can do it with me if you want, okay? Close your hand, open, make an L, okay? You're trying to keep the other 3 fingers closed. You're trying to go into full extension. It's not closed, inflection, it's full extension. And you want to see if the other fingers recruit. Do they open up, okay? Now the goal is to close your fingers all the way down, open them all the way up, and do that as big and as fast as you can, okay? So everybody give that a shot quick. Just give it as big and as fast as you can, but make it stretch, okay? Now when you do that, okay, relax. The funny thing is what are some of the things that you might see if I'm doing this as big and as fast as I can? What might you see? You might splay the other fingers. You fail to maintain flexion of the other fingers, for sure. Yeah, so you got to stutter, or hesitancy is exactly hesitation. That's what it's called, for sure. Amplitude changes, so you get these little itty bitty little, you know, like you're sending Morse code, okay? Somebody sending a telegram. What else might you see? For sure. Y'all, it is amazing how many times I will watch somebody do an exam and a patient has a massive orofacial limbic escape, and the person's like, yeah, that looked normal, but while they're in the middle of doing it, the person's like, yeah, they did fine, no problem at all. Like they're drooling, tongues hanging out, eyebrows all the way up. Okay, you're going to see a bunch of asymmetry show up in an orofacial component, so please don't miss it. People will absolutely do this. Case in point, have you guys ever seen this finger exercise? Okay, what's that? Downton Abbey? Okay, right on. So if you guys do this one, the instruction is one thumb. And remember, most people are going to do this. You want to go into full extension, one pinky, not like this, but full extension. You want to try and bring your arms up to elbow height. And what you're doing is just relaxed, but you're switching as quickly as you can. And you watch, does somebody have a facial escape? Do they change their breathing rate? Do they start spontaneously tripping out with other fingers, right? And then you can do ones like this where you go 1, 2, 3, 4, 5, 6, right? And you see, does somebody recruit the other hand? So watch 1, 2, 3, 4, 5, 6, okay? So you can do all of these things. I can tell you, and we can go all over the place with whatever you guys want to today, but finger exercises are some of the most fascinating dual tasking frontal lobe stuff. In the last 6 years that I've personally been working with kids with nonverbal autism, 100% of them have started speaking within 6 months. And a lot of it is actually very heavily vestibular and very heavily finger exercises. Because what part of the cerebellum controls the fingers? Very, very outside, the new part, right? Anybody know what it's called? Yeah, close, but close, close. The specific part of the cerebellum that controls these. Dentate, okay? Because glenohumeral, elbow, right? Fastigial for the fat part, right? Because I got a little extra, all right? Fastigial for the big part. Glenohumeral is globus. Elbow for the emboliform. Dentate is digits, okay? So dentate for digits. What else does the dentate do? What kind of movement is this? Is this gross or fine motor? Okay. What is probably the most finesse fine motor muscle or section of your capacity as a human being? And what is the most fine motor thing that you have control over? Tongue, for sure. Okay. So if the dentate has the finesse of being able to do finger movements, and I have a kid that can't speak or operate their mouth, buccal muscles, orofacial, tongue, platysma, swallowing, anything in this region, but they know how to move their fingers, and I exercise their dentate part of their cerebellum, what am I also doing? Speech therapy, right? You're going to have a ton of people that have got issues with mouth, swallowing, tongue, all these other things. You get them to start popping off like this, and then you actually get them to rotate through fingers, right? Ooh, I'm messing it up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, close. You get them to do that sort of thing, but then you also add in breathing exercises like right? Oh, let's see if I can do it with the breathing exercise. And you see my left hand started recruiting. I felt it. Come on. There it is. The man, the myth, the legend. So if you guys are looking at doing some of these things, don't forget that if you're looking at the job description of each of these parts and you start doing finger exercises, if you've got somebody coming in that's got an issue with anything from the mouth to the collarbone, and it's going to deal with fine motor coordination. Has anybody ever tried to sing? Is anybody a singer in here? Okay. Anybody try to hum? Right? Okay. Anybody had a cold and you're just trying to clear your throat? Right? It's like coronavirus. It's a zombie virus going around. We're literally getting into the zombie apocalypse at this point. But if you guys are trying to swallow and you're trying to do anything with speech, anybody ever had a little too much to drink? Nobody? Okay. I want to go ahead and say probably most of you have at least once. What are the main areas that get affected as soon as you drink? Can you categorically? Cerebellum, but how does it show up for a person who doesn't know how to say or spell cerebellum when they're very drunk? What happens to somebody when they're drunk? They stutter. So speech is affected. What else happens? Say again? Balance gets affected, so you know the coordination of movement is now different. What else happens? You're the sober one, and you got that friend that you're like, this is going to be a very complicated drive home. Because they can't speak clearly, they can't walk properly. What else are they not doing effectively? Anybody ever get that friend that's had a little too much to drink and all of a sudden they get super emotional? Okay? Like they're weeping openly because they didn't get the extra shot of tequila, right? Okay, so emotions get massively affected, right? Anybody start making some somewhat ineffective decisions, okay? So your ability to make cognitive decisions about what you're thinking and how you're feeling, right? So when you talk about cerebellar activity, not only are you talking about speech, coordination of movement, global muscle tone and balance, but you're also talking about cognition that includes thinking and feeling. So let's put that into perspective for a second. If you have somebody come into the office who has severe anxiety, but they also, you find out they have a movement disorder or they have a balance issue, could the balance issue be exacerbating their anxiety? Possibly. The interesting thing with the research around vestibular disorders is 1/3 of all people who have an anxiety disorder will develop a full-blown movement disorder. 1/3 of all people who have a movement disorder will develop a clinical grade anxiety disorder. Has anybody ever heard that before? Okay. The reason I say that is if you guys are going to do anything in chiropractic, quintessentially, what is a subluxation or a misalignment other than a movement disorder, right? You're getting different information into the brain. So if you've got people who have an actual balance-based disorder and they're having trouble with thinking clearly, feeling clearly, what is the possibility you're going to have patients coming into your office that also have cofactors of anxiety and depression, right? Has anybody ever had a severe health-related issue? Known anyone that's had a severe health-related issue? Okay. How much does it affect how you think and how you feel, right? I personally, and I'm super transparent about it for anybody that knows me, I actually had a suicide attempt while I was in school. And I've had 2 attempts. Fortunately, it was pre-kids. Kids are a good anchor. My kids are incredible people. They're nice. They make me think I could be like them one day. It's kind of awesome. But the thing is when you're a chronic patient and you're going to be dealing with people with really severe things, if you don't take into consideration that there's going to be a factor of anxiety or depression, and that's not your wheelhouse, I'm not saying you're going to be their therapist, but if you also say, let me do an intake that says, how are you doing in those fronts? Because if you get somebody that gets drunk and they get acutely depressed or acutely anxious, they can't speak or think clearly, can't move properly, and can't operate their body, if anybody shows up with any of those symptoms across the board on their checklist, what system might you be able to engage and make a difference in all of those arenas? Cerebellar. Does that make sense? Okay. So why can you work with a kid that's nonverbal and get them speaking by getting them to do finger exercises? Because you're exercising the part of the brain that also manages speech. Welcome, come on, let that door slam, it's all good. Yes, sir. Well, yeah, absolutely, and you've got different maps in that. I'm just saying from a standpoint of the dentate side, part of the cerebellum deals with fine motor coordination. That's why you're going to see a very different relationship with people who have a lot of components of dexterity in their fingers. Like for instance, if an example is piano players. If you see anybody who's a really high-level concert-level pianist, they don't tend to also be unintelligent people, right? So you're looking at these things in terms of activating different parts of the brain. There are kids that I've worked with that have had the most profound speech therapy for 5 or 6 years, but it's not a mechanical issue with the mouth. It's an issue with a part of the brain that onboards complexity. And if you can coordinate this, because the other thing is, how big is the map for each of your fingers? Does anybody know? Okay, if you haven't heard of it, it's the homunculus, or it's called the somatosensory homunculus. Anybody got a paper cut? Hangnail? Splinter? You can't see it, but it's driving you nuts. Okay, it's because the map of that real estate is huge. So the reason I say that is when you're doing a finger exercise and you're like, why is this so hard? It's because you're not coordinating 10 fingers, you're coordinating 10 extremities. That's how big the map is. It's like you're doing your own rocket stance just with your hands. So being able to coordinate finger exercise is huge for cognition, feeling, thinking, speech, coordination of movement, just an idea to kind of intersect around that. The reason I mention that just kind of as an allegory is whenever you're working with a particular finding in a patient, don't assume that the way to rehab that is with the actual location where the finding is. Does that make sense? If I'm working with somebody who's got a speech issue, I might be able to work on it through balance exercises and head positions. And we're going to talk through a case in a minute. Sorry, we're going to videotape it for you, brother, when you have to head out. But Jordan, right? Okay, so we'll talk about a case of a lady that came into the office who was diagnosed with ALS. And if you're going to take in a patient that's got ALS, you're going to have to be comfortable doing a lot of different things that most people aren't, okay? And what we did to help her. So that being said, the one that I don't use as often is piano playing. But again, it's one of those things that if you do it, because most people when they do piano playing, they're actually going to end up just doing this. So the biggest thing I look for is if they start breaking down their ability to actually move individual fingers. And they start to move them in a group, okay? You can also do this one with people where you ask them to try and, if you have their hand all the way open, try and get them to bring the 2 middle fingers together and the 2 outside fingers, like this, but see if they don't recruit the other hand. because I just did it again. This left shoulder, Ellis has been working on this left shoulder for like 11 freaking years. The left shoulder's still pissed at me. So if you try to do this and you see somebody recruit the other hand or something happens in the face, that's a way of seeing, does somebody have a distinct map of their fingers that are different? And piano playing is a way to do that. Cool? Okay. So where did we already get a chance to look at pursuits and saccades? You guys remember? When you're doing finger to nose, right? So as you're getting somebody to chase that finger, when is the appropriate time for you to move your finger? If somebody's going from nose to back out, when is the appropriate time for you to move your finger? On the way out, absolutely. Okay, because if you move your hand before they touch your nose, what do they probably already have? They've got a map of the new location, okay? So you want to change it and even change it multiple times to see how they adjust. And one of the fascinating things, and I know that this is oversimplified, but I can't tell you guys how many people I have worked with and seen get better off of basic breathing exercises. Like one of the most profound things for chronic pain patients that I've worked with is just getting them to breathe properly. And one of the fastest things you're going to see when you get people having to second guess where the location is, they're going to automatically, and they arrest their breathing, they stop it. So if you're doing an exam with somebody and you watch them just trying to track with your instructions and their breathing rate is changing, what's the likelihood that they're doing that throughout the entire day every time they send an email, or they change lanes, or they get a phone call at the same time as they're trying to order at Zaxby's, right? I went and picked up this shirt at Target today, and I don't think I remember seeing that at Zaxby's. That Zaxby's is as big as the freaking Golden Corral next door. I'm like, that thing's a monster. It's huge. Anybody ever eaten at Heirloom Barbecue? Man, come on, y'all. You're so close. Please, do me a favor. Write it down. Go to it. Jesus makes the mac and cheese, okay? It's like, I say that because I ate there today with a couple of people that I was meeting with, and I managed to spill barbecue sauce, Korean barbecue sauce, all over myself. So it's a new shirt. Okay, convergence. Thank you, brother. Does everybody know the basic way to do convergence? Does anybody not know? Don't feel okay. So can I borrow you again for a second? All right. Here's the number one thing that I've seen, and I'm sure Dr. Ellis can attest to this as well. the number one way to get a patient very, very upset with you is to do convergence wrong, okay? It's not cool. Because what part of the brain controls being able to bring your eyes together? Does anybody know? If you've got, let's just say it's a part of your brainstem, for anybody who's not super familiar with the real estate. Think about it, and here's another thing conceptually for you guys, because this is the hardest thing for me when I was in school. I was like, I can't remember all the real estate and the pathways and all the names and all these other things. I'm like, I don't know. But conceptually, if I throw a Frisbee at you, and the Frisbee's about to hit you in the face, and you can't do anything about it, and you pull back, what part of your experience as a human being is probably helping you with that? Is it your rest and digest system where you welcome that experience of being hit in the face with a Frisbee? Or is it the part of your brain that goes, crap, I'm about to get hit in the face with a Frisbee, right? So what does it sound like? Does it sound like sympathetic or parasympathetic? Sympathetics live where? Yeah, thoracolumbar from an active standpoint, but from a management standpoint, mesencephalon midbrain, okay? It's where the Hulk lives, yo, okay? The frontal lobe is Bruce Banner, the midbrain is the Hulk, right? Anybody had a situation where it got out of hand a little quick? You killed a man with a trident, you have to lay low for a while, all right? Anchorman, y'all, it's good. Right? Brick killed a man with a trident. That was amazing. If you Hulk out, it's in your midbrain. So if you pull back to save your face from being hit, because how many people have been driving in a car in Atlanta and a plastic bag comes up off the road and comes to the windshield? Y'all, you're in a car and a plastic bag is coming towards your windshield, and what do? Freak out, okay? Cognitively, what's the chances of that plastic bag doing you any damage? Right? But survival chances. You swerving to compensate for the plastic bag and putting yourself under an 18-wheeler probably going to complicate things. All right, so when it goes flying to the face, what is the one thing when you're doing convergence that you do not want to do with a patient? Probably, if I'm asking you, just close your eyes for a second. Okay, so if I'm doing convergence and I'm coming in, what is the number one thing that I don't want you to do? Well, definitely don't poke them in the eye. I think that's a safe strategy. Don't poke them in the eye, okay? If I'm looking at, like when we were doing the finger tap test, we're looking at different factors, but one of the factors is amplitude, hesitation, speed, those sort of things. So if I'm asking them to follow the finger, the biggest thing that I don't want you to do is don't do it too quickly. Because if you accelerate too fast and you do it as a reflex, you can take it to the bank. The faster the eye movement, the more likely it is going to be a reflex. The slower the eye movement, the less likely. So when you're doing optokinetics and you do them at a really, really fast speed, like anybody uses Optodrum on the phone, you flick it and the optokinetic is going at freaking 80 miles an hour, that's a reflex. The faster the eye movement, the faster the brain has to go. I don't have time to process it, I just got to figure it out. So if you close your eyes for a second, if I do a convergence where I go like this, okay, it's not going to help anybody. Now if you want to check if somebody can get limbic and get emotional on you and start cursing at you, you can do it faster, right? But open your eyes for a second. What I want you to do when you do a convergence is you put your arm up for a second for me, okay? If you want a safe bet, you can always start where the thumb or the finger is. This is a far enough distance. Because as soon as you get into the elbow, more than likely you've already got a degree of convergence, all right? So if you're trying to do like full convergence all the way, okay, you can do it to where somebody follows it in, and as they follow it, you go all the way to the point that they can't do it anymore. Like he actually followed it all the way into that point, okay? But if you're doing it, don't forget, most people do what I just did. When I went in, what's the first thing that I did? As soon as you close your eyes for a second, I went here, what was the next thing I did? Got it? No. If you do convergence, you got to go in slow, come out slow. You want to see how they're able to draw in for both eyes in terms of a medial rectus component, but also what types of contractions do you have? You have concentric and eccentric. If you do convergence and you go slow in, but you don't come slow out, you've only done concentric contractions, okay? So also, here's one of the things. Where was Ryan standing while he was talking before I put my finger up? Right? Did you guys see what he did? He was like this. Actually, head was here. Okay, so he's watching me talk here. As soon as I put my finger up, he goes here, all right? The very first time you do any of your tests in this process, don't correct people's posture. Don't correct their head position. Don't correct their recruitments. Don't tell them just follow with your eyes. You want to see whatever their compensatory strategies are without you giving them any feedback. So can you tilt your head to the right again for a second? Because if I have him here, go ahead and look at my finger. If I have him here, this is a completely different exam. Going here. Then if you put your head on straight. Okay, because with his head tilted to the right, he has two hesitations on the way out with his left eye. He doesn't have with his head in neutral. Because part of the thing that you also got to think about from a chiropractic standpoint is we have a bias that everybody is supposed to be structurally aligned. All right? If you come out of the factory and one of your vestibular canals, and by the factory I mean how you're born and how you're made, if you come out of the factory with one of your canals a little bit off kilter because it's not a perfect 90, and what ends up happening is your body, through a lifetime of experiences, said, I need to have a little bit of bias so I actually have an appropriate writing reflex. And you're like, I really trust the biomechanics and the power that made the body needs to make you straight. It's actually your ego. Because what you have to do is understand that if you straighten this person out and you actually increase their symptomatology and you think that you've made them better, what you've done is decompensated their system that's worked 30 years or 40 years to make sure that they're stable. So understand that you're very, very, very hardcore pushed in school to understand that there is alignment and it is centered. If somebody comes into your office and they have a little bit of a bias with head position or body position, don't assume that it's incorrect. Assume that it is their particular strategy and ask yourself, is that the most effective strategy that they need to be healthy? Because if you change something and you make it worse, it may be that you decompensated a system that spent a lot of time figuring out where it needs to be. You got to have both sides of the equation. Fair enough? Okay? So don't correct somebody on their posture the first time. If I follow pursuits and I'm going and his head starts to recruit, can you fake it for a second for me? Okay? And he starts to do that, I want to get that information and go, what changed about that? Did he only do it in the first pass? Did he did it in the fourth pass? All of this information is great. Because here's the number one thing that I can tell you. If you do this, all of this you can do in 3 minutes, okay? Right, and we'll time it quick and get you guys to practice it in just a second. But if you do this with somebody, you may only get 1 or 2 chances to see something. But what I want you to think about is your goal is when you do all of this, is try and find 2 things that you can list as a biomarker. And what I mean by a biomarker is it was reproducible. It happened enough times that you go, it's consistent, and it's obvious. The reason I say that is the particular way that I run my practice is I am trying to get people out of my office, right? I don't want them to stay in my office. My average number of visits before I discharge somebody is 12 to 15. I don't see people a ton of times, and I only see about 100 people a year. Not 100 people a week or 100 people a day. I see 100 people a year, okay? Yeah, that's okay. That's all right. I'm all right with that. I'm more interested in making sure that people are taken care of. And for me, from a financial standpoint, it's worked out really well. So that's cool. My family's happy. I'm happy. Patients are good. I rest well. I don't burn out. I don't know about you guys, but sometimes that can be helpful. You guys know any chiropractors that are burned out? Right? I know some that are waiters now, and they work at all sorts of fancy places like medieval times because they got exhausted, right? So I'd prefer that you guys don't end up working at medieval times after having a $250,000 debt load. Fair enough? Okay. Is everybody doing okay? Take a deep breath. I'm moving kind of quick. Is that all right? Okay. So when you're looking at the pursuits and the scots, remember, try and make note of what's reproducible, but at the same time, if you have some random pathology or some random finding that shows up, it may only come once. So if you see something that's grossly incorrect, try and see if it doesn't end up reproducing itself. It may have just been an outlier. For instance, just using Skylar's example, if you see something, you're like, man, I feel like that was there, but you can't seem to reproduce it, that is not something that you want to hang your hat on for a diagnosis or treatment intervention. Fair enough? Okay. So for convergence, one more time, what is the plane that makes it easier to converge in and diverge in? Does anybody have an idea? Like if I was looking up versus looking down, which one is easier to separate the eyes versus make them close? So if I'm looking down, are my eyes more likely to separate or to come together? Sure, and if I look up, right? So one of the things you also want to be conscientious of when you're doing convergence specifically is how much flexion and extension somebody has. Because if they're tucked with their chin and they're looking up at you, they're already going to naturally diverge. And then you're doing a different type of convergence and their head is in neutral. So one of the ones that I would harp a little bit more about making sure that somebody's in a neutral position is when you're testing the eyes. Okay? For the OPK, same thing. As far as when you do the OPK, I would say it's safe. It's a safe bet. You want to be able to do a pass over the course of 4 seconds. If you do it faster than 4 seconds, you're checking a reflex. If you want to check their mesencephalon or check their Hulk response or how they kind of freak out or they Hulk out, you can do it faster. But if you want to get an accurate movement, if you've never done an OPK on somebody before, how many instructions do you give them, do you think? When you lift that OPK strip up and you just run it past them. What do you want to tell them? Nothing, okay? You want to be able to lift it up and just run the strip. And if they don't look at it or they ask what you're doing, just tell them it's a reflex. I just want to see what your body does. And then after that, you can give them some more instructions, okay? Have a seat for me, Ryan. Thank you so much. Okay. For gates, is there anything that anybody has? Because the biggest thing that I wanted to do for today was just to reiterate these pieces because you guys are going to keep learning them and to keep reinforcing it and then have everybody kind of do it quickly with each other to pair up. But I don't want to go exhaustively into gate because there's so many good resources that exist. But does anybody have any particular questions in terms of what your experience has been either in clinic or in club or in other spaces in terms of a question related to gait? Yes, sir.
I had a patient who was interesting. He came in with a kind of complaint of stuttering.
Sure.
I don't speak the language his family speaks, so
Yeah.
it was actually really interesting to try to reproduce that through a translator who didn't hear it and all this and that. But when he was
Yeah.
talking, I noticed he had limited arm movement on the right side. He lifts his right foot or left foot high.
Sure.
And he has like tons of permanent reflexes present.
Yeah.
And they're complaining about stuttering. They're trying to start a business in this country. And
Yeah.
only one of the family was speaking English.
Sure.
It was interesting that that was the focus, but we also found out that he has total disorientation when he wakes up, and his pulse ox was like 86 when I first took it, and then we got him to breathe, it even popped up to 98.
Yeah.
So toggled him once, and he doesn't have the sleep issue anymore. He still happens to have the gait thing. And
Sure.
now transferred over to another clinician who speaks the language, and I'm curious.
Cool.
They're going over circle for now, but also be encouraging to start moving that body. I have been doing some cross-crawl stuff just to
Yeah.
be working it.
Yeah. And you know the thing is in that particular situation, so you guys answer the questions for, tell me your name one more time. Alex. What systems are involved in what he just said? So I asked a question about gait. He gave me an answer about gait. What systems are involved? What did he just mention? Just think high level. If it's an employee that deals with a particular thing, what systems did you hear? Because this is the part where you got to try and jump in and see what it means to think like a clinician, right? Because I don't want y'all guys to be doing paperwork. I want you to be thinking about what do you actually do for an intervention, right? So what systems are involved there? Don't worry if you don't feel confident in the answer. Just try and guess. What did it sound like is involved?
Sam Wagner.
Did you just say Sam Wagner? Okay. What system is it? Just one system.
It's like really at a superficial basic level.
Yeah, just high level. What? Okay. Sure. So we got musculoskeletal for sure. Okay. Especially because you just did an adjustment and some of his sleep changed. What else changed? What other systems are involved? What deals with arm swing? Okay, you got cerebellum. What else deals with global muscle tone? Yeah, you got a lot dealing with how you actually executively function. Like, does your brain actually work? Is there a CEO present? Right, so one of the ways that I think about it that can be helpful, guys, because sometimes it's hard to remember all the names of all the systems, is think of it like a regular corporate structure. Who is the person at the top of the food chain in most situations? CEO. What system is CEO level? Neurological, but specifically what lobe in the brain? Frontal lobe. Okay? If you've got a person that's stuttering and they also have primitive reflexes and they also have issues with arm swing and they also have issues with motivation in different spaces, the chances of you having something involved with a CEO level decision maker probably pretty high. Okay? What manages speech? We just talked about. Okay? Cerebellum also does global muscle tone. So you know that you're seeing something, that there's a change in muscle tone, change in arm swing, change in speech. Primitive reflexes, even if you don't know a lot about primitive reflexes, at what point are primitive reflexes supposed to be gone? At 6 at the oldest, for sure. Most of the time, most of them are gone between 18 to 24 months, sometimes 36. 6 for sure, right? So how old is he?
He is 17.
Okay, so at 17, are those things you should be seeing, right? So why I say when we talk about biomarkers is if you don't have a specific thing that's reproducible in somebody and you're just looking at the biomechanics, you're not going to know if you're going to make any impact on the brain. So what are biomarkers that we heard in that in terms of findings? Decreased arm swing? What? High step? Primitive reflexes? And then what's the main thing that they've come in for? Stuttering, right? Right. For sure. And that's the thing. If you have somebody that stutters, just as a trick, what's one of the fastest ways that you can check if somebody can shift hemispheres in lateralization and see if they can change their stuttering? Anybody know? Singing, for sure. Okay? Yeah, they can speak louder, they can increase phonation. But this is why when you look at these sort of things, what's another system that, and you just mentioned it, but another system that you're not normally trained in chiropractic that is going to be really heavily involved possibly with primitive reflexes if somebody stutters? It's going to be anxiety and it's going to be nervousness, right? So if you've got somebody, and this is why I say when you're dealing with more complex cases, and you're dealing with people who are going to be dealing with a lot of complication, as an immigrant kid myself, whose dad spoke 13 languages, being an immigrant and trying to run a business in the States is exciting and scary, okay? So if you're going to work on somebody and you're going to take into consideration an adjustment or an intervention that needs to impact their symptomatology, but you've also got somebody who's getting symptomatic off of their anxiety, what may you need to be conscientious of in terms of your adjustments? These are questions you need to ask yourself. Because if it's a significant enough finding that it can change based on how safe they feel, what system are you definitely dealing with if you're looking at safety? Parasympathetic versus sympathetic, right? If you give somebody an atlas adjustment, are you doing a more sympathetic or parasympathetic adjustment? Well, this is the thing. A lot of people ask that question. It's always both, right? It's always both. It's a trick question. But is it going to be more powerful to do a C1 adjustment than it is to do a T4 adjustment? Depending on, but most of the time, for pure afferentation, if you do a C1 adjustment, it's going to be more powerful. So if you already know that somebody's low on fuel, that they don't even have the capacity to integrate enough to not prevent stuttering when they're in an environment that they feel unsafe, and then you hit them with the megaphone of a C1 adjustment, if it works out well, great. But this is also one of the things that when you look at the integrity of a person's system, if you give them an adjustment and it crashes them, they may not have the fuel capacity to handle it. Dr. Ellis knows this with me. I was put in the hospital 3 times by a very, very good adjustment. Technically, it was an amazing adjustment, but it was too much for my system. Does that make sense? And I know that's heretical. That's like going into church and saying, maybe you don't need Jesus. I don't know. Maybe you don't. Okay? Maybe you had some bad experiences or you're just not ready for it yet. Sometimes you can give somebody the adjustment and it can be too much. So that's something to be conscientious of, okay?
I don't want to take this direction a little, but
Sure.
I'm curious, like if someone has like an NSA or BGI or total background, would that possibly be a better approach because you're working with tonal system?
Yeah.
It's all actively bringing the brain's attention to different places.
Sure, absolutely. And for me, I mean, one of the things that I can tell you, at least in my experience, is it is very, very, very rare, and unless somebody's got a very specific, location-specific, system-specific issue, that you're not looking at brainstem rehab. Like if you guys don't know how to adequately do a cranial nerve exam and adequately translate that into effective therapy, I think anecdotally you're probably missing at least 75% of the resources that you have. Because most people's issues live subconsciously, and they live in their brainstem, and they live in that competition or that competitive space between sympathetics and parasympathetics. Because they're on an inverse relationship, right? They're on a seesaw. So if you're working with somebody who's presenting findings that are limbic, that are stuttering, that are fear-based, that are primitive reflexes, that are brainstem integration into cortical integration, and you're not evaluating the differences between their cranial nerve functions that are sympathetic and parasympathetic, you're just going for pure biomechanics, you have a higher probability in somebody like that situation of bottoming them out, not because they didn't need an adjustment, but you have to do a more location-specific adjustment that wasn't so intense because they're already dealing with enough anxiety. And for what it's worth, just super high level, left brain or right brain deals with anxiety versus depression, if you have the guy's head good. So anxiety is a concern about what? The past, the present, or the future? Past is fear, but anxiety by definition is a fear about something that has not yet occurred. Okay? The left brain actually does forecasting. It's the one that does linear processing and sequencing. It's what allows you to speak. It's what allows you to do deductive reasoning and logic. So if you're dealing with somebody who has an anxiety issue, I don't tend to focus heavily on hemisphericity issues, but just from a pure departmental standpoint, if you're dealing with somebody who has high grade anxiety, like they're constantly concerned about what could happen, the what if question, if I'm trying to avoid slamming the gas pedal on the left part of the brain, what side of the neck do I probably want to maybe evaluate a little bit more intensely before I go hitting it hard from a chiropractic standpoint? The right side, because the right side is the sensory side for the left brain. Somebody who's dealing with massive depression, nonverbal communication and relationship-based environments, that's a right brain relationship-based space that deals more with emotions. Really high level, if you're dealing with a patient that's got a mental health issue, more left brain associated in terms of who's leading the conversation, more emotional health is right brain. So just being conscientious, because I guarantee it, I've had it happen, I'm sure Dr. Ellis has had it happen, I'm sure you've had it happen, that you adjust somebody and as soon as you adjust them, they unfold. Like they start getting really, really emotional. They get upset, or they get weepy, or they get joyful, or they have a demonic situation where there's literally an exorcism that happens on the table, which Draster and I were doing a repositioning maneuver with somebody 2 separate times, and they full-on exorcised a demon following their repositioning maneuver. Okay, so if you don't understand these systems, but again, different approaches depending on what kind of practice you're going for, okay? Cool? All right. So, dual task. I actually, instead of doing the dual tasking with the gait, you can do dual tasking with the gait. My favorite one is to ask people to go between months and weeks or days of the week. Like you'll hear most people say, can you say every other month out loud? I'll actually ask people to go, if I want to make it super complicated, every other month followed by every other day. Start with January, start with Monday, and flip, but you have to skip a month and a day. And then people are like, right, that's like super complicated. But the other thing that you can do is also, depending on the comfort level of the patient that you're working with, if they understand it, just do a serial number and subtraction. And serial 7s tend to be harder, but if somebody's really struggling, don't make it hard. Do it by 1 or 2 or 4, you know, those sort of things. Does that make sense? Yeah, absolutely. And then you can see if somebody gets limbic, right? Okay? Because if you do something with somebody and they start to get frustrated with you in the exam, you're going to have to be conscientious of not only what kind of therapies and interventions you can do with them, but if somebody loses their patience with you during the exam and they're that threadbare, what's the likelihood that they're going to be compliant with at-home exercises? Right? Because I can tell you guys, one of the most fascinating things that I've seen in the last couple of years in practice is the number of people who want to pay you to come in just to do the at-home exercises that they could literally do themselves at home, but they still won't do them, so they want to pay you to do them. Because now you're actually a personal trainer. They're just not going to go to the gym unless they're with you. And that's okay too. but you got to be conscientious if you're trying to equip somebody to do it at home. Compliance is a factor, and if you can see somebody's emotionality during some of your interventions or some of your exams, that also give you some insights as to what you can actually prescribe. And the reason I say that is if you're trying to be effective in practice, part of it is also going to be the intuition of deciding what and how much to give somebody to do for their at-home therapy. Because I've found that one of the biggest things that happened for me with patients is I gave them too much, and it ended up causing them not to start at all because I got overwhelmed. And I was like, I'm going to give you everything that I got because it's the way that I'm wired. But what they were actually asking for was 2 things. Give me 2 things to do, and I will come back next week and we'll make sure I'm doing those 2 things properly. And then letting them kind of build in. Sometimes it can be too much for folks. Okay? Fair enough? Take a deep breath. All right. Anybody got to go to class? We good? All right. So if you time this out, by the way, one of the reasons that I actually originally worked through this 3-minute exam process was when we were in student clinic and you're trying to figure out how to do the 3.5 hours of paperwork for a single adjustment, right? If anybody else can relate. Thank God I was the last class. I think I was the last class before we switched over to the EHR. I was the very last one, and we just never had to do it. Thank God. But the reason I did this is there's nothing in here that you can't do in student clinic, right? Because one of the key factors when you go into student clinic is you have to have been taught it in a class up to that point, and every single one of these things you're going to get taught in one of the classes before you go into clinic. The only one that I always got a little bit of pushback on was the OPK, but you can also do an OPK, you know, on your phone if you want. A little less obvious, a little quicker, okay? So that being said, does anybody have any questions about any of those individual pieces?
Okay, with red and white strip.
Yeah, red and white strip.
And what are you getting for that? I've seen it.
Sure. I appreciate you asking. There's so many things that you could look for, but the biggest thing that I would say in all of these, when you guys are starting in clinic, or you're starting and using this in CHOP and other places, what I would say probably the most effective way to start trying to figure out what it is you're picking up on is just ask yourself right now from an entry-level kind of space, is it different from left to right and top to bottom? That's it. And is it different from vertical compared to horizontal? Because you're going to be dealing with very different systems dealing horizontal versus vertical. So you can compare left to right, top to bottom, and horizontal in comparison to vertical. That can be helpful, okay? So right now, the biggest things also, by the way, you guys, any motor test that you do, DDK, because if you look at it, how many of these are motor tests, okay? If I do a Romberg's and I close my eyes and I have a sway, I don't drop, because how many people drop? Nobody drops, okay? Have you ever had anybody have a positive Romberg's in your office? I mean, how often does it happen for you? Like a full-on close the eyes and boom, they drop.
Yeah.
How often? I mean, is it daily, week?
Once every 2 months.
Yeah, I mean, it's super rare. Okay, it's not like they teach you at school like somebody's going to close their eyes and I mean, everybody's going to die. Like you got to be right there, okay? For what it's worth also, to catch somebody, you only have to have maybe 10% of their total body weight and strength to catch them if you don't let them go all the way past 45 degrees, right? Yeah. Yeah. Yeah, like you can see somebody, yeah, you can, yeah. If somebody's going to eat it in a Romberg, you saw it when they walked in the door, okay? Before, yeah. Yeah. It's like now you're using it to prove a point. They're like, the people who actually end up needing to know that they're going to follow, the people like, oh yeah, I feel pretty good actually, pretty stable. And you're like, yeah, for sure? Okay, go ahead and close your eyes. And then you just, you know, then they're dropping and you go, it's super rare, okay? But when you do a Romberg's, let's see, how many of these involve being able to have 2 compartments, agonist, antagonist, catch each other? If I have a sway, I'm working with an anterior, posterior, or lateral. So I'm having antagonist-agonist relationships. DDK, muscle groups, finger to nose, finger tap, piano playing, pursuits and saccades, muscles involved, okay? Convergence, muscles involved. Concentric, eccentric contractions, right? Hamstring, quads, medial, lateral, rectus. OPK, muscles involved, for sure. Gait, dual task, everything's musculoskeletal, right? All of them have it. So if we go back to the finger tap, what are the 4 main things that we're looking at in the finger tap? We're looking at amplitude, how big is it? You're looking at hesitation. You're looking at speed, do they change speed? Okay. And then, what's the other one you're looking at? Recruitment, and seeing if there's anything else that happens from a spillover standpoint. So every single one of these tests, if you're like, what am I looking for? You're looking for, you can also look at smoothness and accuracy. Hesitation, if you have a hesitation, what do you not have? Smoothness or accuracy, right? And I'm sorry, the fourth one is accuracy. So amplitude versus hesitation versus speed versus actually a location accuracy, okay? So those are the 4 factors. So whenever you look at any of these things and you're going, well, like, what am I looking for? If you say, did I see any change in speed, amplitude, accuracy, or hesitations, and their counterparts? So if it's smooth, it's accurate, it has an appropriate speed, and it doesn't have any hesitations, is it something that you need to worry about? Oh, you move on, right? But if you've got a change in accuracy, speed, amplitude, or you have hesitations present, what's probably the next thing that you want to ask if you're going to use that as a biomarker? I mentioned it a couple of times. I want to see if anybody picked up on it. So let's say that I saw it, and I think I saw it, but what do I need to do? Say it a little louder. Reproducible. Yeah, you want to confirm it. Say again? Yeah, reproducible and obvious, right? Now the thing is here's the thing. Unless you, and this is going to take time to develop in terms of a skill set, unless you have really, really, really good observation skills for super minute stuff, I would really encourage you right now, instead of trying to, die on the hill of being the most observant person in the clinic, go for something that is a billboard obvious thing, right? You need to find something that's not only reproducible, but it's like, and here's my factor for when I'm training people to try and understand the entry point for it. If you could show it to the patient's family member and the family member can see it, that's a biomarker. Hey, can you do me a favor? Can you come here and look at this? Watch this. Close your eyes. When they touch his finger, do you see what happens with that other arm? And they're like, whoa, right? If you can see it as a family member and you don't have a degree, that's a biomarker, right? Because the other thing is part of the confidence level of somebody being able to know that you're making a difference is they have to also believe it's not a magic trick, right? You don't want to deal with placebo and nocebo factors. Make it something that you say, they close their eyes, they're in a tandem gait, I put them on a foam, and they just consistently keep stepping back on that right foot. Every single time they keep stepping back. How many times do I have to do it to go, it's going to happen again? If you've got that, it's a reproducible biomarker. Now, if somebody does this, and I'm seeing that, what's the amplitude, right? Because here's where your biomarker becomes your evidence that you've made a difference, okay? So if there's a titubation, that's different than if somebody goes, and they come back, right? Now I do an adjustment, and the only thing that changes after the adjustment is this. Same, better, worse. Okay, what changed? The amplitude, right? How big the movement was. So if you keep coming back to those 4 factors in any of these categories, all you're looking for right now as you learn the neurology, don't worry about which employee is involved, what system is involved. All of those things will come. But if you can find a couple of things that are reproducible, and then you go, that person kept having that particular movement, that hesitation, that change in accuracy, that targeting with the hands, the big movements, the big jumps in the eyes. I don't know exactly what it means right now, but I kept seeing it. Write down what the biomarkers are, and then take that back and go, there were 4 things when I checked all of that kept popping up. Are they related? Are they different systems? How might they be involved in kind of the chain of command? And then you start to go, overall, what is the conversation in this particular person's system at that particular time? Because if it's reproducible session over session while you're in clinic, or session over session, or even reproducible post-adjustment or post-intervention, then you've got to start to ask the question, is that person's particular compensation, and is it appropriate for me to change it? Because again, a lot of the times we're going to see something and we're going to think it's pathological and we need to fix it because we come in on a white horse and somebody who's going to have a savior complex. I'm not saying it happens, but it happens a lot, right? So you got to take that into consideration as well as, is it appropriate for me to change it? And am I even making a note as to whether or not I made a difference? Because how many times have you guys either been adjusted or you adjusted somebody and you didn't do a post-check on whatever the finding was that you just said, I need to check? That was a great adjustment. Peace out, see you later, right? And the person's like, well, I came in for stuttering. Maybe have them speak. A sentence that you had them do at the beginning before you adjusted them that you know they struggle with, and then they say the exact same sentence after the adjustment, and oh my God, it's better. And you're like, wow, okay, that was helpful. And the patient's going, oh, that was helpful. What's the likelihood the person's going to come back and work with you again? Okay? But if you don't check it and they just know, man, that felt great, I don't know if it did anything. Does that make sense? Okay. Other questions? Okay. So we're going to do the way that I like to teach, and I skipped it at the beginning, is I like to take at least a 3-minute, 5-minute break every hour so you can actually breathe. It's called the Pomodoro technique. I skipped it about 30 minutes ago, and I apologize. So we're going to take a 3-minute break for anybody to make a quick exit if you're like, man, I got to get out of here. Or you just need to catch your breath, but don't take more than 3 minutes. Like when that hits 28, we're going to start back again, okay? Okay, y'all ready? Cool. Okay, let's do it. Let's do it. So let's do it. Yeah, I know, right? I let it. Well, actually, it just hit 28. Do you see that? I was right at the 12. My internal clock was right there. Okay. So, remember, for anybody who didn't catch it, are we still recording, Rupe? Are we good? Yeah. Okay. Assume. Yep. Not for my edification, but apparently people are like, I need to go back and watch it. So, cool? Yeah. Okay. So, when it comes to the side of being able to do each of these individual pieces, remember, if you didn't remember everything that we just went through, Rope is going to send out the link to everybody that actually has the... You guys with me? Ladies? Sorry. Just because it's more that everybody else is listening to you. I apologize. High five. There we go. All the love. Right? Don't worry. Is anybody familiar with the Enneagram? Okay. So I released a book at the end of last year on the brain-based model of the Enneagram and the neuroscience, which we can talk about as well right now if you want, or something else. We can just completely switch gears. But I'm super low in an 8. Like 8 is one of my lowest numbers. So I'm always practicing getting a little limbic in a space that could produce conflict, because I'm like, it's not going to eat me, even though your brain thinks it's a bear that's going to eat you. So thanks for letting me practice that, because I promise I feel way more uncomfortable than you two do. Unless you're also very low in 8, and then I apologize. Right? So, what's that? It's a brain-based Enneagram. So, yeah, there you go. So it's kind of fun. We sold out of the first 3 print runs, and now we're on the 4th print run. Found out this, this is stuff that you don't think about when you're in school, because you guys got to think, I graduated 6 years ago, and I didn't anticipate this, and this is kind of the fun thing of how neurology works. But on Saturday of last week, just a couple of days ago, it was number 237 globally on Amazon out of 8 million books. And I was like, I kept like refreshing, and I was like, I think this is it like that number on a category? Is it like this weird like ancillary, like this is strange clinical intervention recommendations? It's number 237 out of like 240. No, it's actually out of all of the Amazon books, so it's been kind of fascinating. The brain-based Enneagram, yeah, on Amazon. So yeah, and we've got it in hardback now. It's available for pre-order. Again, getting nauseous at the self-promotion, so thank you for letting me do that. Appreciate it. Okay. I have an identical twin brother who hit every branch on the way down to the developmental tree of self-confidence and self-promotion. Dr. Ellis knows him. Justin, my twin brother. Your brother? My twin brother. What about? I was saying he's got a different air of self-promotion about him than I do.
Oh, man, that dude's so swag.
It's funny, when we did our graduation, I did my graduation at a brewery. It's probably the funniest statement that Dr. Ellis has ever made about my brother and I, because he's known us for like 11 years. But we had a graduation at a place called the Wrecking Bar, and I'm trained as a Cicerone, which is a beer sommelier, and I'm a whiskey guy. So I brought like 350 bottles of my own collection for the graduation party. Yeah. Yeah, but it ended up being, it was a really, let's just say there were a lot of cerebellar findings for the night. And at the end of it, Ellis told me the next day, he's like, you know the fascinating thing? You drunk is like your brother sober. I remember that. That was super funny. It's the very first time I introduced my twin brother Ellis. We were at a hotel for I think a movement disorders course, and my twin brother was asking Ellis about a pregnancy issue that his wife was having. Really intense, really complicated. He just had a miscarriage the year before. It's like, I think Ellis can answer this question. He's a mentor. Love this dude's thought process. Let's talk to him. Justin goes through this whole thing, finishes explaining it, and Ellis goes, you know, there's nothing I can do about that without some more information. And Justin was like, oh, okay, I'm with you. It was the gap. You actually had a tactical nuclear penguin. I remember that because it was... Well, that was it. And it was 30. Yeah, it was. Oh no, you had the Westfalen 12. Yeah, Westfalen 12. It's the #1 rated beer in the world.
Yeah.
But it's made by monks, and you can only get it at the brewery in Belgium.
Yeah.
Yeah.
That was the best beer in the world.
Yeah. It's called the Westie 12.
I was in Germany, down south.
Yeah.
I can't remember the city right now, but Munich.
Munich.
Yeah. So I'm in Munich, and they're like, dude, the first beer brewery is here. Like, you got to stop going to the Hofbräu house. You have to go to the. Where are you from? Yeah. You got to go to.
Yeah.
So then they're like, that kind of sucks. You got to go to some other place. So I go there because I know he's one of those things he said, and I photographed the thing. I go, where am I? And he was like, they had this little 400-year-old plaque. And he's like, oh man, he goes, that's on my list because you're at the first place they made beer like in the world.
Yeah.
I'm like, this is fucking awesome. I'm like, give me the original stuff. I'm like, I want to go to the original barrel, the original stuff. I almost died. I was like, what am I drinking? And I was upset. I called him. I don't know what time it was in America.
Yeah, it was early, man. It's like 3:30 in the morning.
And I'm drinking. I'm drinking.
You're drinking history.
Coors Light, man. And he was like, well, yes, all the original American beers you were founded after that formula. It's like Coors, Bud.
It's a Pilsner. It's a basic Pilsner.
Original beer. I was so pissed. I thought we had this great European beer.
Yeah, like the Westie. Yeah, no, that was not at all the same. Yeah. So this is where Ellis and I are at this point. He's calling me at 3:30 in the morning, being upset because of my beer recommendations. So that's what you guys can also have if you also have a mentor in neurology. So, but one of the things is. Yeah, exactly. Yeah, it's a different space. So here's the thing, and I am actually fascinated. Half of the room left, which is fun because I'm glad that you guys are still here. Because now what we're going to do is I'm actually going to tell you about a case that I had at the beginning of the year, and I want to give you guys an idea of what everybody thought it was. Here's the thing: this is not to be able to get you to understand how to do this. It's to get you to understand how powerful functional neurology is in a practical way, as well as when you can take on some really complicated cases. But there's some gap between getting to the point where you can do this and where you are now. So I just want to give you some encouragement. You can get there, but don't worry about understanding all of it. I just want to give you the concept of it. The best piece of information or advice that I ever got from Dr. Carrick, and I remember where I was standing in the NeuroLife before they'd even rebuilt it out, and I said, what is the most important thing that I need to understand? He said, worry less about the details and be more interested in understanding a concept. If you understand what a system does and what it's responsible for, don't worry about how it does it, worry about what it does. So concepts are much more important than context. So don't worry so much about the details, that will come, okay? Like playing a guitar, how many chords do you need to learn? Okay, 3 mainly, but how many chords are on the guitar? You don't even have to use them, and there's only 6, okay? But once you understand it, you can start writing your own music and doing something complicated. But don't stress about the details, understand the concepts. So I had a lady that came in, she got a hold of me at the end of last year. I'm a 100% referral-based practice. I do appointment only. It's very hard to actually get into the practice. You have to be vetted. I do what's called the Candidacy for Care program. You cannot come in unless I approve you for care, because I wasted a lot of money seeing providers who should have told me not to come in before I came in, and it really frustrates me. So I don't do walk-ins, and somebody cannot just get on the schedule with an open appointment. We vet them, we make sure that they're there, and then for them to get in and on the schedule, we will not give them an appointment time until they put a 25% non-refundable deposit down. So by the time they show up in the office, they also have to have their paperwork done. If it's not done, we'll reschedule them. So by the time somebody gets into the office, they have gone through it to get in there, right? So we make that barrier to entry there. But this lady started the process in September of last year. She was diagnosed with ALS and was under the impression that she had a limited window of time, okay? ALS is not something that you get diagnosed with and you're like, this is going to go well for me. But listening to her case history, because here's the thing, I'll be totally honest with you, I don't take a lot of ALS patients. I have right now on my active patient roll that I have 3 patients that have ALS, and that is all 3 that I've done in the last 3 years. And they're all in at the same time. 2 of them, I think, have some sort of variant of a muscle wasting disease, but I don't think it's ALS. One of them definitely does, and we're trying to make it work for the next 12 months. I mean, it's really, really intense. But also, I know that I have enough humility and my ego is not so fragile that I can look at somebody and go, I have other people that I think I can trust this with. So know your limitations as well, right? But when talking to her and having her explain it to me and seeing what she filled out in the intake paperwork, I was like, this doesn't feel exactly like that. I don't know what it is yet, but it doesn't feel exactly like it. So she got diagnosed with that in last year, we're talking in August, she went to a couple more neurologists, and then they said, we're going to shift this diagnosis to a cramp fasciculation syndrome. We don't think it's exactly ALS, we can't rule it out, but we think it's more cramp fasciculation. And now she's developing a complex regional pain syndrome where she's getting what kind of neuropathy findings, where she's having profound sensory pain, burning, lots of other issues that are happening. So when she came into the office, she came in on a Wednesday, she could only make it for 3 days. It's actually a pro bono case that I did. I do about 10% of my care during the month is free, and she's one of the people that I took on as a referral. And when she came in and she started describing it, she had all of these fasciculations, and if you guys don't know what fasciculations are, they're kind of the tremors in the muscle that are too fast and too fine to be a gross motor, like you're not contracting a calf, you're getting like, it looks like ants crawling under the skin or worms moving under the skin. She's got severe intense pain, and if she walks more than 200 steps, everything locks up, her pain goes through the roof, and it takes about 3 days for her to recover from the pain, the burning, the intensity of the situation, how much her calves lock up and how much her legs, all the way up to the knee. And she can't sleep because she's getting so much muscle tone in terms of how much she's cramping, but she'll get these massive cramps, she'll get the fasciculations, and she's getting the burning pain. She's already come off of an ALS diagnosis that was confirmed and then taken off the table and then put in as a backup. So she's stressed through the roof, right? She's 62. And when she walked in the room, again, the reason I'm telling you this is every single thing that I found out with her, I found out off of this initially. I didn't need anything more. I confirmed it with some other sensory findings, because if you have a longer exam, obviously a full neuro exam, you can go as long as you want to. But the biggest thing that I actually did with her to confirm it was just watching her walk. Because when she was walking, you can actually, one of the really quick ways to see is just to ask somebody how often they wear their shoes. And if those are consistent shoes that they wear and they've got different tread wears, you can get a ton of information off of tread, right? So when she was walking, she just had this really, really unique kind of process of trying to step over the front of her feet onto her heels, and then also had a little bit of a shift in her balance from where she sat down and got up. A lot of different head position pieces that she was doing, and she just felt really organically walking into the room through lots of training in other spaces. She felt like she was dealing with more of a vestibular issue than she was a muscle wasting issue, right? So in doing the exam with her, one of the things that I would actually get really, really, really comfortable with is doing a basic balance exam, which I wrote down a couple of these things, but then you can also have 6 more head positions, just to kind of see what somebody's bias is for how stable they are. Because when I have a similar equipment to Dr. Ellis, have a posturography system. You could see it bedside with her when she closed her eyes, how she was compensating by actually loading in a different position. She was constantly leaning back. But when I put her on the balance pad and put her on the foam, she also had this secondary issue where, and this is one of the reasons they thought it might be ALS and they thought it might be a muscle wasting issue. She had the symptoms start in her legs, and then it started to translate into her arms, and she was having a lot of sensory findings in her arms. She's also a licensed massage therapist, so they're like, is it possibly an ulnar issue, an entrapment issue? Is there something wrong with the nerve? Because she's getting bilateral issues in both of her hands that look exactly like ulnar issues. Like she looks like she's having a ton of stuff. Now it's happening bilaterally in all 4 extremities, and people are starting to freak out. They're starting to think it's a big issue. She gets on the balance pad, she gets together, she closes her eyes, and she keeps doing this, right? She keeps compensating by doing this motion. So if you see somebody with a center of pressure issue where they start to lose their balance and go backwards, even with their eyes open, what does somebody tend to do? If you're talking about primitive reflexes, there's actually one that you can do with a baby where they'll throw their arms out, right? You can look at Moreau reflexes, you can look at Landau reflexes, you can look at parachute responses. If somebody loses their balance, what is the likelihood that they're going to recruit their arms? High, right? Super high if you step in different positions or you lose. So just to accelerate the conversation so we can also kind of unpack it and talk about some other things if you guys want with the time that we have left. looking at what was happening with her, she consistently was on her back heels, and asking her what had happened, she kept saying, well, it started 2 years ago and we don't know what happened. But this keeps showing up in my body like this. And this is also a fun story of how patients don't tell you everything during the exam and the case history until you start working with them. And they go, oh, I think this might be relevant. And you're like, oh my God. Okay, so I'll tell you that in a second. So she's like, this started happening over 1.5 years, and it just kept getting worse and worse and worse, and then the arms came in. Long story short, what ended up happening was she had just spontaneous disconnect and some miscommunication in her vestibular system that she kept getting a posterior center pressure. Now, she was working an increased workload as a massage therapist, so she was in an anterior position. And at 61, 62, what she had done is plasticized her anterior canals. So she was overcompensating, in my opinion, with trying to have a posterior center pressure. Now, she loads back, and she's loading her calves. She ends up getting massive fatigue in her calves, and they start to cramp constantly because she's got a slight posterior position. Now she's doing it over and over and over again. She's getting a exacerbation or a micro trauma or an overuse injury. And now all of a sudden, now what she's getting is she's starting to get, anybody ever done a really, really intense workout and then afterwards your muscles twitch, right? Well, she's spending the entire day weight bearing on the back of her heels, and she doesn't know it. Now as it starts to get worse and worse and worse, she starts to compensate with her arms. So every time she's walking around and she shifts her balance just a little bit, and she doesn't even realize she's doing it, watch my hands, okay? She's walking around, and as she's walking, she's doing this, right? She's just slightly doing her fingers like that. She closes her eyes, goes onto the foam pad, and she's doing, no exaggeration, this much movement. What is she doing with her fascia in terms of constantly going into extension, specifically like she's doing a toggle? She's getting a traction injury, and one of the fastest things that you can do, and Ellis knows better than anybody if you guys do his stuff, what is one of the #1 findings and the #1 symptoms that people report if they're having fascial or nerve-based pain? Burning, high intense pain, and all these other issues. So what she's getting is she's getting global fascial traction injuries that are presenting like nerve issues. So she's getting all the nerve conduction studies, but nothing's coming back on the nerve conduction studies. Her nerves look fine, but it's presenting with the exact same type of electrical and burning pain that's similar to a compartment syndrome or similar to something that's happening with a nerve-based issue or a muscle degeneration issue, but she's got no atrophy. She's got no loss in her muscle mass. She's got no loss in strength. She's got massive symptomatology. It's happening in all 4 extremities, and it's because she's bilaterally loading on both of her legs, and then she's also constantly compensating for this vestibular micro fall that she keeps happening. She's tractioning her elbows. So I looked at it and said, I think this is a really, really, really ideal candidate for a repositioning maneuver. And I use a lot of repositioning maneuvers, y'all, like a lot. I've been using them for 6 years in my experience, and I don't do them specifically for a vestibular complaint. I actually do them for afferentation, to turn on and integrate different systems, especially based on my exam. And it is insane how much stuff it fixes, because there is no older system in the human experience than the vestibular system. It's built before your spinal cord. It is the only system, and this is a fun little fact that you can tell your patients. Out of the 5 primary sensory systems, nobody really learns about vestibular and movement. All of the 5 primary sensory systems are all secondary systems. They're not primary systems, because you don't actually use taste, touch, sight, sound, or smell until you come out of the womb really effectively. And if you lose taste, touch, sight, sound, or smell, your brain will figure it out. You lose the ability to have an effective relationship with gravity or movement, your brain will die, okay? The vestibular system and movement is the primary sensation. All the other ones are backups or secondary systems. They come later. You develop vestibular in utero. It's important. So if you use vestibular responses to actually rehab somebody, you can fix that like a lot, okay? It's insane. So we ended up doing, I did the balance exam that I checked with her and figured out what I felt was a primary offender for what was going on. We did 1 repositioning maneuver with her, and as soon as she got up from the table after the repositioning maneuver, she was asymptomatic in her arms. So I had no pain in her arms, and then when she closed her eyes, no more recruitment in her hands, right? Now, did it stay that way over the course of the next 3 days? We had to work through that. It actually ended up happening that she had a little bit of soreness in her arms that she thought was just from repetitive stress injury massage. But she actually, from the moment that she had the repositioning maneuver to now, which has been 10 weeks later, she's had no symptoms in her arms. Completely resolved that. The pain in her legs went from an 8 to a 4 in her legs, but it was still there. And then what I end up doing is treating people in the real world. I don't treat them in a bubble. I ask them to specifically do something that they've been hesitant to do, And she was there for 4 sessions, 4 one-hour sessions over 3 days. We did 12 sessions. I asked her to take a walk around the neighborhood because how many steps, if anybody was listening, how many steps could she take before she had an exacerbation? 200, okay? Remember, always be listening to the data that patients are giving you. It's important, all right? So she ends up taking a walk. She goes, man, I walked for a while and I started to get a little uncomfortable. I think I'm like up to a 6 or a 7. I said, well, how many steps did you take? She goes, I don't know. Normally I can do about 200 steps before I get uncomfortable. She's got a pedometer on. She goes, oh, I forgot I got my smartwatch. Let me check. 2,100 steps, right? Same day. And she's like, I didn't even realize. Now, did it exacerbate? Sure. But then what had ended up happening is we do the repositioning maneuver, take care of the initial compensation that's causing all of that, knocked her fasciculations down by about 80%, ended up changing her contraction of her cramps. So she's now got a decrease in the complex regional pain, a decrease in the fasciculations, a decrease in the cramp, and a decrease in her overall pain. Here's the next 2 things that are really important. If you've got somebody that just got diagnosed with ALS, and when I'm watching her, she's having little itty-bitty limbic escapes in her face. It looks like fasciculations in her face that they also think are related to the muscle wasting, but she's having spontaneous little movements. You guys, I can guarantee it, unless somebody has an actual muscle wasting issue and they've got something like that kind of high-end severe diagnosis, you see spontaneous movement in the face, you need to have a conversation with their midbrain. Because from a primitive standpoint, an animal is spontaneously doing things with their face for what reason? They're either trying to scare you or they are scared, okay? From a primitive standpoint, you have spontaneous stuff happening in the face. There is something happening in their midbrain. She's spontaneously twitching in her face and she's changing her breathing rate. I know for sure, based on her history, not only being a patient but being a provider, how scared is she at the moment? She just got diagnosed with ALS, y'all. Like, there is no way you Google that and it works out well for you. You go to Google getting a puppy and you're 12 pages in with cancer, okay? You go to Google something like ALS, it's not going to make you feel better. So she's ramping all of this up the whole time without any clarity or answers because she's also gone to how many specialists over the last 2 years? 14, 16, right? Which is why she's bankrupt and I'm seeing her for free. It's like, it's hard. But then I'm looking at this going, here's where I quickly fast-tracked it in the exam because I only had 3 days with her. And I want to see how quickly we can fix it, and also I need to check that it's going to stick. Because anybody can get a system to respond. It's to get the system to respond and make it a new norm. That's actually a quote that I use with patients all the time, just to intersect this quick. It's actually not that hard to get patients better. It's hard to get them better after they get better and then they get worse again. The hardest thing for a chronic or a professional patient is not having a good day or getting better. The hardest thing is getting better and then losing ground. That is difficult. If you don't know how to make it stick, you're going to have 3, 5, 10 times the effort of reinforcing what it is with somebody if you gave them a taste of it and they lost it. That's a hard place for somebody to be in, speaking from experience, okay? So what ended up happening is I have found a really interesting cofactor with a lot of the people that I work with. And this is my personal bias. You attract sometimes what you deal with. This is my own history, and everybody attracts their own thing. I work with a lot of people who have anxiety, a lot. And it's clinical grade, it's intense. I have personally never worked with an anxiety-based patient that doesn't have significant sensory findings, specifically ticklishness or withdrawal responses. If you have somebody that's got high anxiety, their plantar reflex is a home run for an insight, okay? And the reason this is really important is, can you tickle yourself? If you can, some people can actually trigger their own withdrawal response. You are dealing with a very different brain. That's like a Romberg's, okay? It does not happen often, but when it does, you're dealing with somebody who is not integrated well, all right? You're probably dealing with a lot of factors. But if somebody's high anxiety, almost every single time they're hypersensitive to touch, okay? And if you've got your entire largest organ in your body, which is skin, anticipatory to touch, concerned that something's going to touch it, having a withdrawal reflex or a Babinski or a startle response, what is the likelihood that every time their body is encountering some degree of touch, even with clothing or with air, that they're spontaneously triggering that subconscious startle response, right? You guys ever walk down a set of steps you've walked down 100 times and you miss the last step? Okay? What happens when you miss the last step? You miss it and you're like, I welcome this experience, right? What happens when you miss a step? You freak the fool out. Right? You're a grown human being, properly integrated and healthy, freaking out, right? Because your body is that good at saying something's not right. Now imagine she's got a balance disorder and she's got hypersensitivity to touch and she's spontaneously sparking off all the time and she's having a limbic response where her fasciculations are coming in because her primitive system is like, I can't regulate the muscle tone in your face or your body. I can't do it. I'm freaking out. People get scared in a fight and they start to shake. She's been shaking for like 2 years, right? So complicated stuff. But what I do is I just check the plantar reflex, see how hypersensitive they are to touch. And here's the thing, some people will say, well, I'm not ticklish. If you are ticklish and you can hold your legs, like you can control, you can gate the withdrawal response, you're still going to see somebody recruit a quad. Because no matter what happens, if you want to have a withdrawal response, but you can plank your legs, I need you to be able to let me scrape the bottom of your foot, and you don't recruit anything from the waist down. There should be no movement from the waist down, like no compensations. If you compensate, it's a degree of startle response or withdrawal, okay, because you're sensitive. So I did this process with her that I'll explain to you guys quickly that's fascinating, that I've found really interesting, that if somebody's been ticklish for 40 years, on average, you can get rid of their ticklishness in less than 2 minutes. Okay? And here's the way it works. What you do is you confirm that they've got the ticklishness, and then you take a reflex hammer, and you use the rubber part of the reflex hammer to touch their foot, and you see how sensitive they are to the reflex hammer, but then start using a gating mechanism. Use colors, use serial 7s, use a cortical distraction, use something that they can go. So she's a massage therapist, so what I got her to do is actually to start to go through all of the techniques that she's been trained in, and to start recalling her favorite muscle groups to work on and to tell me where they're located. So she's narrating this out loud. This is her dual task. And as she's doing it, I'm flipping from the rubber side to my finger, to the rubber side to my finger, to the metal side, to the rubber side. So I'm flipping it, and then I'm touching with a finger, rubber, metal, finger, and I'm changing the textures. And then what I start to do is I start to rub it harder, and then I rub harder with my finger, and then I go light. So I'm pushing, and then I just barely touch. And then I start to tickle, rubber, metal, tickle, deep pressure. Because as soon as you go deep pressure, completely different receptor than light touch. Because what is the light touch pathway? Anybody remember? It's dorsal, DCML, but what's the specific pathway? It's called spinothalamic. It's blank and light touch. What's the first word? Anybody remember? Spinothalamic does blank and light touch. Pain. Okay? So if somebody is ticklish, they are also dealing with a pain syndrome. They just don't think of it as a pain syndrome because they think they're ticklish. Spinothalamic is both light touch and pain.
I noticed as a kid that the doctor always freaked out when kids were tickling. My sister and I were tickling, but now we're laughing.
Right.
It's because they're detecting pain.
Yeah, absolutely. Because light touch, this is why you can't tickle yourself. It can't be the stimulus, clearly, because you're doing the exact same thing as I'm doing. But that anticipation of that startle response or that sensitivity to touch is really, really profound from a limbic standpoint, right? So if I can do different pressures and different textures, and they're doing cortical gating, what they end up doing is they guard, and I tell them, relax, loosen your face, take a deep breath, drop your body out, keep saying it, say it louder, say it louder, say it louder, say it faster. Take a deep breath, relax your face, don't grimace, drop it out, and I get them to constantly keep dropping their body into a neutral position and gating, frontal lobe down. The CEO keeps stepping in, they take a deep breath. Within 45 to 90 seconds, almost every single person with the exception of maybe 2, and that's up to 2 minutes, they can get to the point where you can actually see their withdrawal response decrease, and then I tell them, stop, take a deep breath, pay attention to your feet, and I go straight into the bottom of the reflex hammer and actually start really scraping their foot. And they're like, that doesn't hurt, doesn't feel weird. That feels actually pretty normal. And then you start doing all sorts of textures and actually trying to get them to have a withdrawal response, because what happened was they just gated their startle response, and they stopped having that anticipation. And as soon as you stop anticipating that it's going to be uncomfortable, what does it become? Manageable, becomes doable. So now you've got somebody who's hypersensitive to pain, because once you guys study PMRF components, you study global muscle tone, you study Renshaw cells, you study pain gating, you study all of these other things, you'll see a parasympathetic response in that part of the brainstem. As soon as you decrease the pain response and you gate it and somebody shows up and controls themselves, tone changes, startle responses change, withdrawal responses change, sympathetic responses change, and boom, somebody can breathe again. And all of a sudden they're not freaking out through the biggest organ that they have. So the reason I say that is this lady, diagnosed with ALS and a cramp fasciculation syndrome, had a disconnect in her canals. We did one repositioning maneuver to change her center of pressure. Statistically showed that she was actually completely centered, but she didn't need it. I mean, she's going like this the whole time she's on phone. We do one repositioning maneuver, and she's like, she's got a little compensation, but it's 80% better. She can feel it. Then you change her sensory response to her hypersensitivity to touch, and her pain went from a 4 to a 2. And this is really important. If you deal with a chronic pain patient who knows what an 8, a 9, or a 10 feels like, if they get to a 3 or lower, it is a 0. And you need to tell them that, and they need to say it to you. Because if you deal with people who have been at an 8, a 9, or a 10, I've been at a 10, okay? I've had over 2,000 unique migraines. My migraines are between 6 and 7 most times. 8s, I'm considering going to the hospital. 9, I'm at the hospital. 10, you better kill me or I'm going to kill myself. That's a 10. If you're at a 10 and you're still considering being on the planet, you're not at a 10, okay? That's a different space. So if this person knows what it's like to have to go to the hospital because of their pain and they get to a 3, I always ask patients, if I could drop you from an 8, which you walked into, to a 3, would that be manageable? And they're like, I wouldn't even care. If it's, yeah, I can do that. As soon as we get you to a 3, I'm going to remind you, and I need you to tell me it's a 0 because you don't think it's relevant at that point. It doesn't matter. And as soon as they do that, they allow their body to go, don't anticipate the problem, and then boom, they drop to a 0, and within 48 hours, a lot of times they can actually be at a 0, because you're also talking about feedback, positive and negative feedback loops of trying to gauge all of these things. Because if somebody's hyper ticklish, and you even go to tickle them, what is their response? It's like, it's not funny anymore. It's not funny anymore, right? Because people get emotional. So when we did this with her and got rid of her ticklishness, as soon as we got rid of her ticklishness and she stood up, and she had just had the repositioning maneuver done the day before, because I just did the repositioning maneuver, she comes back the next day, we see how her body integrated all of that. Then the first thing we do is a sensory piece. At that point, within one repositioning maneuver and about 12 minutes of actually doing sensory responses, she was asymptomatic. She'd had this issue for 2 years. She went from having ALS to being asymptomatic, and it took about 13 minutes of total treatment, right? That's freaking nuts. But what it was she had an anxiety-based disorder that had an origin space in her movement system that kept making her feel like she was missing a step every single day. And it's freaking her system out because she's a calm and collected person who spent years doing meditation, but she can't get over this unbridled anxiety that she can't figure out. And talk therapy is not doing it. But adjustments, vestibular care, proprioceptive rehab, and parietal remapping, boom, knocked it out in 13 minutes. Now it would fluctuate, it would come back and forth, but it was because I was taking her and making her walk on a treadmill for 3 miles that same day. She went from 200 steps to 3 miles in the same day. I'm super aggressive, y'all. Because I believe that people's systems can integrate that way, but you better be comfortable with doing that, because if you bottom somebody out, you're gonna have to fix it, right? So in my rule, just for what it's worth, if I bottom somebody out and they run out of money, then I'm seeing them for free because that was my fault, right? Not their fault, but that's my way of doing things. But yeah, it's an example of where if you look at somebody and they come in with a severe diagnosis, if you're looking at a proprioceptive issue or sensory issue, and you're looking at something where there's a muscle-related component, like she's having cramps and fasciculations and tons of movement in her arms, if you don't feel really comfortable with evaluating and intervening in the vestibular system, get comfortable with it. Because the 2 biggest arenas that I can tell you that help patients are going to be vestibular and brainstem related. Because if you adjust people and they get better off of one adjustment, you're probably looking at something biomechanical. Thank God, that would be amazing. I would love, 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 during my lived experience, to have gotten one effing adjustment and it made things better. That is not my story, right? And for some people it will be, and that's freaking awesome, and you celebrate that. That's cool. It doesn't always happen. So if you see somebody and that doesn't get better, get comfortable with vestibular and brainstem work and doing a cranial nerve exam. And interestingly enough, if you look at this, dorsal column for brainstem, okay? Cerebellar for all of these. This is also, and obviously frontal lobe gating, but this is pontine. This is, if you do it fast enough, this is not only frontal but also midbrain, so brainstem. Midbrain, brainstem, midbrain, brainstem, midline, all of it, and then frontal lobe to midline. So almost all of this is actually subconscious systems, brainstem or cerebellar systems. It's not cortical, it's not cognitive. Most of the time somebody's getting hit the same way they would if they get drunk. And I can tell you one of the fastest ways to figure out somebody's intervention and somebody's susceptibility is ask them to be very honest with you how they show up if they have too much to drink. Because if they tell you, man, it is a window. It's like a magnifying glass. It's like X-ray. It's a really, really easy way. And if people are transparent with you about it and they're willing to talk about it, and you let them know, look, if you know what that looks like or someone else knows what shows up, is it more balance? Is it more emotion? Is it more speech? Is it more, cognitive processing? What happens? If you can tell me that, it fast tracks us to being able to help you. And it's a really fascinating way for people to be able to get some insights. Cool? Right? Okay. We recorded it. I went a little bit quick, but you guys can go back and watch it. All right. So I don't have a hard stop, but you all got to go for lab studies and exams. So I'm going to hang out because it's now 7:05. If you guys have any questions, but at the same time, if you got to head out, feel free to do that. Okay. But my kids are going to be in bed because I live in Grant Park, so there's no rush for me. I've already missed bedtime, so we're gonna catch up with them in the morning. But if you guys have any questions, I'll hang out. Cool. All right. Thanks for being here.
Thank you so much.
Yeah. You're awesome.